Okay, all right. Hello and welcome to The Computer Will See You Now. My name is Simon Watt. I'll be your host today, and we are going to be talking with lots of scientists from UCL and the CMIC unit in particular, two groups called POND and Arctic. Those are a lot of acronyms, and hopefully along the way we'll discover what they mean. This is coming live-ish from the Bloomsbury Festival. We should have been there talking to people in person, but as you can tell, there's kind of a pandemic going on right now, so we're here on Facebook instead. We're joined by a great many scientists. We'll be talking to them, learning about the kind of work that happens behind the scenes, and perhaps even how it is working in a pandemic, trying to conduct cutting-edge science when everything seems to be against you, and none of us can get anywhere near a lab. So let's kick off, and would you mind if we go straight to Jamie and Katrina? Because I'd love you to tell us, actually, what is CMIC? Can we begin there?
Hi, thanks, Simon. Yes, so CMIC stands for the Centre for Medical Image Computing, and it's a group of scientists here at UCL. We're a mixture of computer scientists, medical physicists, a few clinicians thrown in there as well. We're lucky enough to have one of them join us today. And we work together trying to use computers to help solve the problems in healthcare at the moment.
Yeah, well, it's good to see that tech is kind of being used in these good ways. And I know there's a very good saying that any sufficiently advanced technology becomes indistinguishable from magic. When I look at the things that we're doing inside the body, it seems to be getting stranger and stranger. To help guide us through this, Katrina, I know that you've made a sort of poster, which will talk about your work in radiotherapy. So would you please introduce yourself, tell us what you're working on, and then we'll dive straight in.
Thanks, Simon. So yes, I'm Katarina, and I'm a cancer researcher at the Radiotherapy Image Computing Group in CMIC. And my work focuses mostly on childhood cancer. And I have prepared a short presentation to guide you a bit through the different work we do and also introduce you to the world of radiotherapy. So Jamie, would you be happy to share the slide?
Yep.
Well, that's coming, Katrina. Can you tell us, a lot of people are sort of scared about the word radiotherapy because it does imply radiation. Is radiotherapy dangerous?
No, not at all. So that is actually a common concern that patients and their families and the general public in general have. And I can say that radiation has been used with great success for the past century to treat cancer. So yes, it's considered safe and it's also very effective. And there's a lot of misconception going on about radiation. I would associate because of nuclear disasters and like atomic bomb effects, but that's not what we do when we treat patients with radiation. And also, we do a lot of checks in the treatments we do to make sure that we're delivering it safely and that the dose of radiation is going to the right place.
That's very reassuring. So please take us through your slides.
Yes, so we'll start by giving you a brief introduction into the radiotherapy pathway. So what a patient will go through as they go through their radiation treatment, and also how computers are being used by our group to help improve safety and effectiveness of those treatments. So yeah, thank you. So as I just briefly tried to say, radiotherapy, we use high energy radiation to treat cancer. And there's different ways that we can treat cancer, including surgery and chemo. But radiotherapy is actually used in around 50% of all the patients that go through treatment. So it's a very common and safe modality. And the aim of the treatments is that we give as much dose as is required to kill the tumor, while we try to avoid any surrounding healthy tissues as much as possible. How does it work is there's these big machines that emit the radiation, and they target it inside the patient's body. And it kills the cancer cells actually by damaging their DNA. And it's actually quite interesting that there's a few fun facts about radiotherapy, and one is the radiation is invisible. It's also silent, and usually patients don't report any pain during the treatment itself. The next step of the radiotherapy, the patient is told to come into the department after the referral. And the first thing we do is acquire a computed tomography CT scan. So this is a 3D image that we acquire that lets us see inside the patient body and see all the information about the anatomy. And the doctors then take these images and they use them to draw around the tumor, which is the target of our treatment. And this target includes the gross tumor that you can see, but it also can include microscopic structures that are not clearly visible. And they also use this information to draw any organs and tissues that are close to it, and so that we can personalize the plan to try to give as less dose as possible to them. So you can see an example on a figure to the right, where, for example, in this case, a lung cancer tumor, and you can see the lungs and the spinal canal would be considered some examples of organs at risk there. And it's interesting because nowadays, although we have these very complex images, most of these drawings actually done by hand by the doctors.
So this is actually one part of the radiotherapy pathway where you could expect computers to play a really big role in the future. In fact, they're already starting to play a role here currently. Using state-of-the-art machine learning methods, computers could be trained to automatically draw around the tumour and the organs at risk, freeing up the clinician time for more important tasks such as seeing patients. The recent methods can already produce very good drawings around the healthy organs, because these are quite similar from one patient to the other, so it's easier to learn. However, it's still quite challenging to get as good results for the tumour, because these can obviously vary a lot from one patient to the other, and they also require more of the clinician's expertise and previous experience when they draw around them.
So after the patient comes for their CT scan, then it's the time where the radiographers and the physicists will do the best treatment plan possible for that particular tumor and surrounding anatomy. So the aim is you choose a set of beams such that you can build up the dose to that region. And we use exactly the CT scan and the delineations from the previous step to guide this process. And nowadays, state-of-the-art radiotherapy machines, they're actually able to rotate around the patient and give the radiation from many angles, which helps to build up the dose to the exact area that we're interested in treating.
Now, the radiotherapy treatments can actually take several minutes to be delivered. And obviously during this time, the patient will try and remain as still as possible so they can deliver the treatment accurately. But there's certain motions, such as that caused by breathing, that is inevitable and we can't prevent during this time. Therefore, a big area of our work has been developing sophisticated computer models of the breathing that enable us to estimate this motion and estimate and account for this motion when planning and delivering the therapy. And I think one of our postdocs, Bjorn, will be telling us a bit more about that later.
So one thing about radiotherapy is that it is actually a fractionated treatment. So we deliver the same bit of the treatment for several days over several weeks. So we give it in several goes. And now the patients, they are treated exactly as Jenny said, in the same position every day, exactly as they were for the initial CT scan that they had. And as part of the process, make sure they're always in the same position every day. We have a set of cushions and other devices to position the patient. And then we acquire images of the patients with, for example, X-rays, to make sure that the positioning is correct, so that the beam is targeted at the right place every day of their treatment. And the actual treatment, where the beam is on, it's quite fast. It only takes a few minutes, but the slot for radiotherapy fraction is way longer because we do spend so much time with the positioning of the patient.
So the images that are acquired just before treatment, these are not only helpful for helping us make sure the patient's been accurately set up, but we can also use them to see the changes that may have occurred to the patient because of the treatment, which may mean that the plan that was originally made is no longer suitable, or at least optimal for them. So if we look at the images shown on the left here, we can see the tumour, which is circled at the moment, has actually shrunk by the second image, which was acquired about halfway through treatment after a couple of weeks. We can also see there's a big hole that's appeared in the middle of it. As well as changes to the tumour, if we look at the outline of the patient, we'll notice that it looks like the patient's actually lost a bit of weight, which is a very common side effect during radiotherapy. Now, while these scans are great because they enable us to see what's happened, it's very difficult just by looking at the scans to actually assess what impact that has on the treatment. And that's where the computers come into play. So we can use the computers to automatically measure the changes that have occurred to the patient just prior to treatment. And even more so, we can actually deliver the treatment virtually inside the computer to simulate the treatment and assess what changes, the anatomical changes, will have made to the treatment.
Now, after the patients are done with their treatment, we will always follow them up for months and years after. And one of the things we follow up for are side effects of radiotherapy. Now, serious problems are quite uncommon, but they can occur. And so therefore, after treatment, the patients will come back for further CT scans and other types of imagings and tests, as well as questionnaires about their quality of life, so that we can monitor if they're developing any side effects from the treatment, and also to make sure that the tumor has responded properly to the radiation that was administered. Now, the side effects that occur will vary with the dose that was delivered, and also with which region of the body was irradiated, so they're not necessarily exactly the same for all the patients. Some will occur quite early into the treatment. A very common one are like skin burns that patients start to experience, but some of them can take months to decades to appear, as are, for example, new cancers later on.
So one of the side effects from radiotherapy we've been studying over the last couple of years in our group is damage caused to the lung tissue from the radiation itself. We use a variety of image processing methods and techniques to analyse the images that have been acquired before treatment, and again follow-up months or even years afterwards. We use these methods to automatically assess and quantify and characterise the changes that have occurred. And the aim of this is then to try and find relationships between the damage that has occurred and the actual dose that was delivered to the patient. And the long-term aim of this will then be able to make treatments safer in the future.
Now, Edward Chandran, you work with this kind of stuff. You're one of the clinicians that work with the team. Can you please tell us exactly what you do in your research and how it fits into what we've heard so far?
Yeah, sure. Thank you. So my name's Ed Chandy. I'm an oncologist currently working with the Arctic team doing research. And one of the ways I treat patients with cancer is with radiotherapy. For radiation oncologists, one of our main concerns is that the radiotherapy we prescribe is delivered to the right part of the patient, as we've just been hearing from Jane and Katerina. And good imaging technology is essential for that. So as we've heard, patients are scanned before and regularly during their radiotherapy to ensure the beams are delivered precisely to the tumour. During a course of radiotherapy, which can take up to 6 weeks, the tumour and the normal surrounding anatomy is constantly changing. If we think about a lung tumour, the tumour can move every second as the heart beats. It can move up to 20 times a minute as the patient's breathing. And it also changes over days and weeks as the tumour shrinks. And the lung itself changes shape in response to the radiation or in response to other events such as infections. So in recent years, the incorporation of daily CT scanning before and sometimes during and after every fraction of radiotherapy has helped us ensure the tumour is always at the centre of the target, and if necessary allows us to make a new radiotherapy plan if there has been significant anatomical change. We as clinicians hope that as imaging technology advances, we'll be able to increase the utilisation of real-time 4D imaging that will allow us to track and adapt the radiation delivery ever more precisely. And this may allow us to use increased doses of radiation to the tumour and reduce the doses of radiation to surrounding normal healthy tissue. And this should result in ever more effective and better tolerated treatments.
So this is part of the aspect is, of course, getting this technology to clinicians. People are going to be using this in hospitals. Katrina, could you take us through what the other aspects of the team working on this are?
Yeah, so yeah, certainly. I think working in radiotherapy has this interesting part that we work as a very multidisciplinary team. And from a patient perspective, you think of a doctor first, but the ones that do go into the department, they will also deal with the therapists themselves, the people that will give them the treatment day to day. It's also important to think about the planning side of things, and that's where the medical physicists and the dosimetrists at the hospital, they are the ones responsible for creating the plan and all the quality assurance that goes through the equipment, make sure it's working as intended. And then I would also like to highlight the people that are a bit behind the scenes like us, which are researchers, in our case, mostly engineers, computer scientists and physicists, that we do a lot of work on trying to develop more advanced techniques, particularly in imaging our group, to make the treatment safer and more accurate.
So it's a big team with many facets. Jamie, I know that you're one of the leads in this kind of stuff. Can you tell us what are the other challenges, I suppose, and benefits actually to working in a team like this? Because clinicians and engineers don't actually work together as much as people might think.
No, that's true, Simon. And at times it can be a little bit challenging because we seem to speak different languages. But that's why I think it's important that we do work together and we do have the chance to interact and learn from each other, because it really is a multidisciplinary field, and you can't make progress in it if you're not all working together. Nobody can understand the full complexities of the problem, from the clinical aspects, from the technological aspects. So it really is about bringing everybody together and working on it together.
What would you say is the kind of key ingredient for making this thing work? What's the advantages of working in this team?
What's the advantage of working in this team? Well, as I say, I think that the team is certainly is much greater than the sum of its parts. It enables us to do things we couldn't individually. I guess one other point to bring up, I mean, it's not only do we need a fantastic team to work on this, but there's another key ingredient to our work, and that's having good access to the clinical data. And that's one thing that working closely with our clinical colleagues brings us, because without access to real clinical data, we can't make any real progress in our work. This is particularly true in the modern age of machine learning, where there's the potential to do really amazing things, but this relies on having access to lots of good quality and realistic data. Now, access to data is actually a bit of a complex and potentially contentious issue. There is potentially vast amounts of data available in the NHS for doing this kind of research, particularly in radiotherapy, where they regularly have multiple scans before, during, after treatment, as we've already been discussing. And when speaking to patients, actually the vast majority of patients are happy for their data to be used for research, even though they're going through quite bad times themselves. You know, they're really keen to see things be improved in the future. But the problem is kind of how we go about making that data available in a way that everybody is happy. I mean, one option is we can just simply put all the data up there on the internet and make it available to everybody. I think I should stress at this point, by the way, here I'm talking about anonymous data. So it's been completely de-identified. You don't know who the images are from. We don't need to know about the people and their personal background for our research. We just want to have their images. But even so, just making it freely available to whoever wants to download it is a perhaps, understandably sort of slightly scary and dangerous way of doing things. And the other factor is actually people have realized this data can be worth a lot of money. Some of the companies are willing to pay a lot of money for this data in order to make their products, which will actually, eventually make the company richer. And should we be giving it to them for free? But if not, who should get that money? Where should it go? How should it be distributed so that we all benefit from it most? And I'll be honest, there's no easy, straightforward answers to this. I don't have all the answers, but I think it's one of the key issues we need to address at the moment. And the only way we're going to do that is by actually having conversations with the public, with patients, with companies, with the government, and making sure we can come up with a set of procedures that everybody's happy with and really enables us to realise the full potential of the current technology.
So to dive a little bit deeper into that, I'd like to now bring in Adam Schul. Adam, you're a recent postdoc working among the team. I'd love to tell us please a little bit about what you're doing and working on at the moment. But then I really want to get down to what are the clinical applications of having access to this data that Jamie's been telling us about. We can't hear you, Adam, or I can't at least.
Yes, thanks. Thanks, Simon. Hello, everyone. My name is Adam Schmuel, and I'm a postdoctoral researcher in radiotherapy image computing group. I work on analyzing radiation-induced lung damage, which is a side effect of lung cancer radiotherapy treatment. In radiotherapy, images require annotations. For instance, there is a need to perform manual contouring of computed tomography scans, which can consist of hundreds of images per patient. So this is a very laborious and time-consuming task. With the progress in machine learning algorithms, we think we could assist in this task, making it more efficient and potentially even more accurate. However, machine learning, just as Jamie mentioned, are very hungry for lots of data to create accurate methods. Currently, we are developing a method which will automatically identify different types of lung tissue pathologies in computed tomography scans. This method could be automatically run on hundreds or thousands of scans and potentially help us to better understand side effects of radiotherapy treatment. Performing such annotations manually would be extremely challenging in terms of time requirements.
So this does seem to be one of those places where computers can save us an awful lot of labor. So
Yes.
Are they going to be replacing people when it comes to this kind of thing?
That's a very interesting question, and there is a lot of debate about that, both in the scientific community and in the general audience. Some people fear that the computer methods will replace humans. I don't think that this will happen anytime soon. In my opinion, computer methods will be very helpful in assisting humans. They can make their work more efficient, take care of some of the repetitive tasks, and allow clinicians to focus on the challenging parts. Let's take lung segmentation from computed tomography as an example. Approximately 90% of the task is relatively straightforward, and this is potentially the job for a computer to do. The remaining 10% is complex and requires comprehensive clinical experience. Allowing a clinician to focus only on the remaining challenging part would be hugely beneficial in terms of time management. So, in my opinion, we should think of humans being supported by the new technology rather than being replaced by them. Especially now, as the healthcare sector is struggling with shortages in medical staff, such help is very much welcome and needed.
So to delve a bit deeper into this, I'd love to bring you in now, Bjorn Iben, if that's all right. Have I pronounced your name correct there, actually?
Yeah.
Iben, yeah, well.
Yeah.
I'm very pleased that my getting progressively European. So actually, in that case, I'd love to bring you in here because I know that your research has been mentioned by Jamie earlier on, that you are looking at how people move. So can you tell us a bit more about how motion modeling works and why this is a problem for radiotherapy, full stop?
Yeah, thanks, Simon. Yeah, we in our group have worked a lot over the recent years with motion models, and essentially we want to think, or we want to understand how things move internally while patients are breathing. And when you think about breathing motion, it's not just breathing in and out, it's about like a whole variety of types of breathing. Like think about shallow breathing or deep breathing, breathing into your chest or into your belly, and then all different combinations of that. And that becomes particularly interesting when you think about lung cancer patients. And that means the tumor, if the tumor is placed within the lung, it's constantly moving. And this is a moving target that you try to hit with the high intensity radiation that Katerina introduced us to. And at the same time, you of course want to avoid other organs that are moving together with this respiratory motion, with the breathing motion. So we want to incorporate this information about this motion into the planning process, into the monitoring of the radiotherapy, and eventually also into guiding that treatment as well. But already getting this kind of motion information as precisely as possible is a difficult challenge. We think about a scene that you want to acquire. Actually, there is a bit of an analogy, and they always say never do a live demo, so I'm going for that now. So it's a bit like taking a scene, a panorama of a moving scene. So let's try to do this. So I switch to panorama mode and actually try to take a picture of this scene while I keep constantly moving my head. And let's see what comes out there. I've got a few examples to back up this. But essentially, oh yeah, that didn't turn out too badly. So essentially...
Just in time for Halloween. Perfect. Thank you.
Exactly. So that's the thing. If you take a picture of a moving scene and you assume there is no motion happening at all, so that's probably the worst possible assumption. And And you have to deal with this kind of limitations exactly the same when you have like a medical imaging device like a CT scanner or an MR scanner. And then, like, assuming nothing is moving is obviously wrong. Then you can do the next better thing and they say that breathing is always the same. So that would be the next better assumption. But we actually have worked on the motion models, which actually try to incorporate these different types of breathing from this partial information that we acquire over time. So maybe I can share my screen here.
Yes, because you have an animation, because this is exactly the kind of stuff that you're actually creating as part of the research, is an animation to understand how we move so we can better target. Is this actually one that you use in your research?
Yeah, exactly. So if you think about when I was moving the camera around, the camera was moving or was acquiring constantly images at the same time. And we can do this here, if I can get this started. Oh no. Yeah. So we can, it's not, we can do this with a clinical scanner as well. So here we took MR scanners from left to right while the patient was breathing constantly. And these images we then put into our algorithm and just didn't stitch them together as they were, but we kind of fitted the motion model and got more information about the moving anatomy. And what we got is a clear, crisp image of the anatomy. But also what we get as a second part of the information is actually how the motion is happening. And you've seen this earlier. And so here we can see in detail how the patient is breathing, how things are moving internally. And in the bigger picture, this means now, how can we incorporate this information effectively into the planning process and into the monitoring of radiotherapy, like how much dose was delivered to which organs? Because probably what I should mention here, while I only segmented out the lung here that you can see now, we have this information for the whole patient anatomy. So you see it over the whole field of view that was covered by the original images. And for me personally, that's kind of the part when you put things through the algorithm, the results come out great, and then actually you put like the cream on top, and then essentially just make a nice visual that is used over and over again, which is actually quite fun.
Cream on top of an algorithm. Perfect. Thank you, Bjorn. But dealing with the motion of the body is only one of the challenges that we have when dealing with radiotherapy. And here to tell us a little bit more, we have Reem Ahmed. Reem, can you please tell us, how do you fit in with this team? What are you working on?
Hi everyone, my name is Reem and I'm a postdoc in the Arctic group at UCL. And Katerina mentioned earlier about the idea of risk models when she gave her presentation, and that's another aspect that we are trying to look at, because there is some associated risk, and specifically within the group we're looking at trying to develop pediatric models and look at the radiation risk to pediatric patients, because they are quite sensitive to radiation, but it's still a course of treatment that is offered. So we want to kind of produce accurate models that can essentially move along with the development stages. So if you have a patient who's an infant compared to a toddler, compared to an adolescent, they're quite different in their developmental stages. So we're trying to develop models to look at that, to assess the risks. So that's basically what I'm helping Katerina with at the minute.
How did you get into this? What was your reasoning for studying this area? Because it's so broad, so many things happen. Why was this the one that took your interest?
I think it's just, I thought it was very important work, because I think it's something that we don't necessarily consider when we try and do research. We think of human anatomy and we don't necessarily think, oh, with pediatrics, it changes quite a bit. And there are quite a lot of changes that occur in anatomy if we're talking about prepubescent, postpubescent anatomies, then everything's a bit different. So specifically with pediatric cases, it's quite interesting and important.
We learned an awful lot about how the modeling is obviously very reliant on computers, and it is remarkable to think that computers are playing such a role now in surgery. How do computers fit in with what you do?
Well, one aspect is that we're trying to devise anatomical models of pediatric patients. So we're trying to develop age-specific and gender-specific models that are not necessarily linked to a specific patient, but generally representative of a specific age group and gender group. So that's where the computers comes in, because we need that to help us develop the actual models.
Now, that's interesting. So can I just make sure I've understood this correct? Are you telling me that men and women, say, breathe in different ways or different patterns?
So our work is not specifically looking at the breathing aspect, but it's more looking at the anatomical differences, because I said we're working with pediatric patients. So anatomically, they're quite different if it's a 1-year-old and a 5-year-old compared to a 16-year-old.
Terrific. Thank you ever so much. I'd love to bring you back in here, Born, because as we can see, there's a great difference between the research that Rima is doing here and the kind of research you're doing. I'd love to know what is the benefit of collaborating in these kind of groups where you are working on such disparate things.
I think it's very much, I mean, when you think about, well, my everyday work is very much like a lot of coding, a lot of programming, but then essentially this is just a tool. Essentially you try to solve a bigger picture, you try to fit in and solve a bigger problem. As Jamie mentioned earlier, you can't just solve things on your own. And this is what I really find fascinating when working in a multidisciplinary team, is like the conversations that you have, they go into unpredictable directions. And one of these memories that will always stick with me during my PhD and postdoc time at UCL, I was always really happy to be able to actually get in contact with a real clinical workflow, with a real clinical need. So for instance, we spent some time, so a PhD student and I, we spent some time at the Royal Marsden and followed like a clinician for a whole week and essentially got to know the whole radiotherapy workflow in person. And the patients, when they were so accommodating, they really allowed us in and really led us into quite personal consultations that they were going through. So for us to get an insight, so there's a huge amount of collaboration that they are willing to offer, and that's so valuable from a perspective that you usually don't have during your everyday work.
Thank you, Bjorn. So we've been hearing a lot about sort of how diverse this team is, and we can see there's people who are postdocs who've completed their studies and are now in the world of proper hardcore research. And there's people who are at the PhD level, where they're not only contributing to research, but also studying. I'm going to come to you, Ademi Akitonde. Would you mind telling us a little bit about that kind of bridge and how it changes? Because you've recently become a postdoc, am I right?
Yes. So, hey everyone, my name is Ademi Akitonde. So currently, I'm transitioning from a postdoc, from a PhD into a postdoc in the same Arctic group. For me, one of the main differences between, actually, there's the day-to-day working between the two is quite similar. So at the end of the day, you're still doing research. However, one of the main differences is the type of research you're doing in a way. So in the case of a postdoc, it's very rigid in the sense that you have a goal of delivering a specific kind of research within a time frame. However, with the PhD, there's slightly more flexibility in terms of the direction that you can take your research into, because the PhD is slightly longer compared to a postdoc. And
I have to jump in there, Adi, because you're basically making sound like your life's got worse. So can you tell me, is there any advantages of becoming a postdoc?
Yeah, I'm going to come back to it. Yeah. I'm going to come back to it. So with the postdoc, you have the opportunity of actually working with more people. So it's more of a team effort rather than just one person doing the main work, which is the case of the PhD most time. And also within a postdoc, you don't have the daunting task of writing like a mini book at the end, which is what you have to do in the case of a PhD.
Terrific. I'd love to now come to you, please, Danielle, because you're going to be, sorry, Daniella, if we could come to you, please, because you're going to be going through this process, hopefully in the not too distant future. You're still studying your PhD. Could you please tell us who you are and what you're working on at the minute? Daniella, I think you're still muted.
Sorry.
You don't know how many PhD students just did a drink there.
Sorry, hi there. My name is Daniella and I'm a second year PhD student. I work with Katarina and Reem for radiotherapy in predicting secondary effects in pediatric patients.
So can you tell us a little bit more what it's like being a PhD student? And actually, I'd love to know what it's like right now, given that we're living through a world-changing pandemic. Your life and your studies has been greatly affected, surely, by this. Tell us how it works.
Well, it really depends on the project. So, for example, there are different types of projects. Some are more computational, and it's my case. So, because of that, I haven't been really affected by the current situation because I can do all my work from my laptop from home. But other projects are more experimental. Some other projects could also have a commercial impact if they have a partnership with different companies. So, well, probably, yeah, those projects have been more affected.
Thank you. Let's learn a wee bit more about PhDs. So can I please come to you, Tommy? Would you mind introducing yourself and tell us why did you choose to study what you're studying?
Yeah, hey, my name is Thomas Klinge, and I work as a PhD student in the Arctic group. My project deals with developing new treatment planning methods for a device called the Gamma Knife. So for me, to start out with, I studied just general physics to begin with. And one thing that I noticed throughout my time at university that was at any point when I got my degree, like my bachelor's degree and then the master's degree, it was of course an achievement, but at the same time, it just made me realize or changed my perspective to see how much else out there that I felt like I still needed to learn. And every time I thought, well, the next degree is going to be the one. But so far that hasn't happened. So doing a PhD is sort of the natural conclusion that is just always the next step ahead of that. And what I like is that here at UCL and in the Arctic group, it's something that's actually, hopefully in the future, going to help people. And I always during my studies, had that feeling that that's the biggest part that was missing. I'm not a big fan of just doing research for the sake of just knowledge. I'd like to see the application of it down the line. And just at UCL, the environment doing a PhD is such that I can just every day more or less go out there and learn a new skill or a new ability. And it's just, there's, as you can see with this group around here, there's most likely somebody around there who either did something in that direction or can at least tell me, well, here, go that direction. And after a week or two, you just learned a new skill. And then, yeah, down the line, my motivation is that at some point, I'd like my research to be actually applied either in a device or as a technique, as a clinical technique. And then being in the knowledge that I literally can contribute it to potentially hundreds, thousands or millions of people benefiting from my work. And that's really what makes this the place to be.
Yeah, it is one of those things we have to sort of connect back to, isn't it? Is that what sounds like academic study for many of our lives, and for many of us, I'm sure it's that we are looking at code, we're looking at computers all the time. But on the far side of it, this will save and improve the lives of so many people.
Exactly.
Let's take that forward, actually. Can we now come to you, Christy? Would you mind telling us a little bit about your research, your work, and why you're doing it?
Yeah, of course. Hi, I'm Christy. And I'm also a PhD student. I work with Jamie, Adam, and Ed currently on looking at the long-term effects of radiation therapy for lung cancer patients. And I actually I got into research immediately after my undergraduate degree. And I think as somebody who's like so early in their like career as a researcher, I found it really fascinating how much more enjoyable it is to learn in such a hands-on application. I've really enjoyed being able to look into things myself, go off, and like even if there's something I don't know, I can just look it up and know the appropriate people to ask. And in general, I've really kind of enjoyed and been a little bit surprised by how much more fun it is to be able to kind of go off and do your own work without having somebody lecture you and teach you and say, you know, this is how it is, that's how that is. And I think especially in the kind of work that we do that moves so quickly and evolves so quickly, especially when it involves both people and computers, it's a lot more rewarding, I guess, to be able to do the work on your own rather than like study from a book, if that makes sense. And yeah, overall, as a PhD student, I guess specifically in this field, I really enjoy the process of collaborating with the researchers and getting to see the clinical application or the potential clinical application that our work could have in the near or far future.
Thank you so much. So everyone we've heard from so far is from the Arctic group within CMIC. Jamie, can you remind me what those two acronyms stand for again?
So Arctic is the Radiotherapy Image Computing Group, and we are part of CMIC, the Centre for Medical Image Computing.
Yeah, and there's lots and lots of groups that there are within the Centre for Medical Imaging and Computing. And we're now going to talk to another one of them, coming from POND. We've got Neil Oxtoby. Neil, would you first of all kick off telling us what does POND stand for?
Thanks, Simon. Yeah, POND is the Progression of Neurodegenerative Disease group. And where CMIC broadly looks at medical image computing, answering unsolved questions in medicine in all the wonderful ways that the human body can unfortunately go wrong. We focus particularly on brain diseases and neurodegenerative diseases, age-related conditions that happen as the body gets older. This covers lots of different things, but the challenge here is to piece together a longitudinal picture of these conditions that tend to play out over periods of decades by piecing together shorter time windows from patient cohorts recruited specifically for research for a particular condition, from observational cohorts, and from even just hospital data direct from the healthcare system. And the challenge there is to deal with all the heterogeneity. These things play out differently in different individuals, different groups of individuals. Diseases can progress at different speeds, have different onset times, all sorts of amazing challenges for us to come up with, both on the medical image analysis side and then the later medical image computing side of the disease progression model itself, which ultimately aims to turn this medical data into numbers that can be used in the same way where an experienced medical clinician will make a judgment call based on their years of experience. We'd like to be able to turn that into something a little bit more concrete and a little bit more consistent from making numbers that can be used to benefit ultimately healthcare.
So can I understand this, do I understand this right, Neil, that say some of the examples we've heard of so far to do with like trying to understand, for instance, how the body moves so we can treat it. You're trying to categorize perhaps the nature of different types of disorders and maybe even how they might change. You're kind of like you're kind of monitoring how things change over time, whereas these other people are monitoring how they perhaps work with motion. Is that right?
It's different scales. So motion happens quite quickly and it happens in a single experiment. Our diseases, our conditions that we're interested in play out over a much longer time. So motion in the process of acquiring a medical image for us is an issue, but is not as much of a problem as it is in radiotherapy for lungs, for example, as has been made very clear by the Arctic team. What we need, the main challenges that we have is to understand how these things play out differently between people. And they do. There's a lot of variability even within a single condition. The motivation, though, is to help a large number of people. It's very much the same as the Arctic motivation. And as we get older, as we live for longer as a global population, these age-related conditions are becoming even more important, both for the patients themselves, for the carers and the family who have to live with these conditions often for a very long time, and the society in general, who broadly has to support that process. Yeah.
Well, that makes sense. There's definitely a real need for this. Can you share with us any of the sort of exciting end of this stuff? Like, what are the kind of changes we might be able to see? What kind of treatments will be developed using this kind of technology?
For example, Alzheimer's disease is the most common neurodegenerative condition, most common cause of memory-related dementia, which happens mostly when you're quite old, over 65. But it does vary quite a bit. And so we can detect Alzheimer's with different measures. Most recently, we're getting some blood-based measures, but often that involves different kinds of brain scans. And we can watch as the brain shrinks over time. The problem is you can't watch enough people from 10, 20 years before the symptoms appear, before anything goes wrong, before you go to see a doctor, which is when you can see these problems. And that's probably too late to intervene. So one of our challenges is try to understand what's happening before that. And we use all sorts of methods from across computer science and mathematical modeling and algorithms as well that we develop ourselves, and some of which we take off the shelf to understand the what is going on, and then also to look at more about how and how the disease mechanism is actually playing out from an observational perspective, from a mechanistic perspective.
So this is really partly automating diagnosis to some degree?
No, it's quantifying it. The diagnosis ultimately will still be supported by our algorithms rather than be replaced. We won't be replacing clinicians anytime soon. But this can make it more consistent. You know, some of those repetitive things, it can help speed up the image analysis, the reading of the images by the expert clinicians.
Terrific, thanks so much. I'd love to actually expand this out to the rest of your team. Anna, you're a PhD student working with Neil and the group at the moment. Could you please tell us what you're working on, introduce yourselves, and then afterwards I'd love to see again how the PhD experience has changed given that we're living in world-changing times.
Yeah, so my name's Anna and I'm a PhD student in the POND group. My work is looking at modelling how these neurodegenerative diseases spread through the brain. So how the PhD has changed since sort of lockdown and everything like that. Well, similarly to the majority of people on this call, my work is largely computational. So I've been lucky that I don't have to go into a lab and all the labs are closed. So I've been, yeah, lucky that I haven't had to deal with that sort of restriction on my work. I also think something that's been quite beneficial of doing a PhD in this time is that the work is quite sort of solo, and so the fact that you are doing it from home rather than in the office doesn't really impact your sort of day-to-day work that much. However, a downside of that is that because you're sort of because you're doing this work by yourself, the interactions in the office and sort of group meetings and things like that are just a really nice time to sort of share your sort of day-to-day working life with other people. And I think it does feel very, yeah, a bit more isolated doing it from home.
Let's hope it doesn't last. I think that's the key. I can't bear to think what this would have been like maybe 10 years ago when we didn't have even means like this to each other right now. So Anna, you're one of the PhD students here. Peter, you're very much looking at the sort of impacts of these sort of things going forward. Can you please introduce yourself, tell us what you work on, and I suppose what the next stage of some of these things are?
Yeah, thanks, Simon. So I'm a postdoc and I'm working in the POND group. And I mainly work on developing computational models of disease progression. And specifically, the application focus that I have is in Huntington's disease, which is a devastating neurodegenerative disease. And as part of my research, I work quite closely with the Huntington's Disease Centre at UCL, which is a separate group that we collaborate with. and has been alluded to during this discussion. This is one of the key strengths of CMIC, is that we do a lot of collaborative research to translate the models that we develop into something useful. So one of the things that the Huntington's group at UCL are doing at the moment is running a clinical trial, or helping to run a clinical trial in Huntington's disease. And the aim of this trial is to try and develop a disease-modifying therapy for Huntington's disease. So some sort of drug, essentially, that will slow the progression of the disease and ultimately improve people's lives, is the aim. And where we come in the POND group, as Neil mentioned, is that our models of disease progression, one of the benefits that we get from them and that we're trying to establish is that these machine learning models and computational models can be used to try and identify the right person at the right time with the right treatment. And the reason this is difficult to do is, again, as Neil said, in progressive diseases such as Huntington's disease or Alzheimer's disease, it's very difficult to find the right person at the right time, because these diseases progress differently from person to person. And it can be very difficult for a medical doctor to just be able to tell from assessing a person at a single visit, say, as to how their disease is going to progress. And so we're trying to use as much information as we can, like medical imaging, clinical test scores, and so on, to try and characterize individuals using these models. And then really what I'm trying to establish in my research is whether these models can be used to improve clinical trial design. So can we try and, in some informative way, select people for the clinical trial to try and increase the chances of it being successful?
There will be people out there who are suffering from these unfortunate conditions, or people out there who know people who are. You know, these are wide-ranging, common diseases, unfortunately. Can you tell us, I suppose, how long do these kind of processes take? Because we don't want anybody leaving with false hope, but we know that the work is marching on steadily. Can you tell us a bit more, please?
So do you mean the processes in terms of our research as to how long it takes to develop?
I suppose it's how long does this kind of research take to actually end up in a hospital helping people? If you're talking about the trial stage right now, what comes next, and how long is this kind of process in general?
Yeah, so that's a very good question. I think that question can be split into two parts. So in terms of the development of new disease-modifying therapies and clinical trials, it can take several years, and this is a very complex process whereby the trial has to be successful, and there are various stages to the trial. You have to show that the drug doesn't have adverse effects, for example, and this is something that we can see at the moment with trials for COVID-19, that some of these trials have had to be halted because adverse effects have been found in individuals. And so you need to get through all of that, and then you need to go through all the approval and the legal processes and the litigation, and then the drug needs to be produced and marketed and so on. So it can take several years for a drug to come to market from development. In terms of our research, I think we really do fundamental research, and what we're trying to do here is really push the envelope in terms of what is possible currently using computational methods, basically, to try and improve and clinical practice and assist medical doctors in their decision making. And the timeline for that is, you know, I think we're at a very critical and exciting point in history where a lot of things are coming together at the moment in terms of computational power, in terms of research. There's been a lot of developments in the field of machine learning recently, and it's really exciting, basically, to be working in this at the moment. And you can be optimistic and say it could happen in the next few years. It could take longer. And I think a big part of this really is us just understanding as much as possible how we can make an impact. And that's why our position here at CMIC is so great, because we get to talk to the real doctors.
Yeah, so as Pete was saying, in the POND group and in CMIC more broadly, we take very much a target-driven, applications-driven approach where we are driven to solve problems using medical image computing and mathematical modeling, real problems in the real world, healthcare, that are, the biggest challenges in 21st century healthcare, shall we say. And one of the beautiful things about the Centre for Medical Image Computing, CMIC, is that we have all these different groups doing different things. We can bounce different ideas off each other. And a recent example of that is actually our plans, funnily enough, for POND to work with ARTIC, the Radiotherapy Image Computing Group. And Jamie might like to say a little bit about that.
Yes, thanks, Neil. Exactly. I mean, as you were saying, I think this is the real strength of CMIC, is having all these different groups working on quite different applications, but potentially developing methods that can be used by each other. So as Neil says, you've been developing these models of modeling how the disease progresses in the brain over time. Now we're looking at the lung damage caused by radiotherapy, which also occurs over time. And one of the things we're really hoping to do in the next couple of years is use the models that Neil's been working on and adapt them for our own application. Now, just going back to what you were saying earlier, Simon, about how have we been infected by the pandemic? I mean, I think Anna made a great point. Actually, all of our day-to-day work, we can do quite well from home on our own. The bit that's really missing is the chance conversations that happen, you know, after a seminar, over a cup of coffee, down the pub after work. And that's where we come up with these ideas of, oh, I can do what you're doing and apply that to my work. And that's the bit I really hope we do get back to soon.
Well, fingers crossed, and to a great audience out there, we know you're deeply affected by that too. So, first of all, I'd love to thank everybody who's joined us for this conversation on Facebook Live, and for Bloomsbury for hosting us. We're sorry that we're not there in person talking to you all. If you want to learn more about the work, check out the UCL website. There's all sorts of things going on, and the team here that we've been hearing from will be going to music festivals next year, should such things still exist. Also, keep your eye on the news, because this is genuine science which will have real-world application one of these days. So from Simon Watt, that's me, all the Pond crew, the Arctic crew, and everybody at CMIC. This has been really pleasant. Thank you, Bloomsbury, and good night.